Hey everyone, Will Brink here, brinkzone.com. Today we're going to have a follow-up topic with a guest slash partner in crime here to discuss a very, obviously very popular topic these days, which is the GLP-1 drugs. And I did a sort of generic position video on it a couple of years ago, which my position and thoughts on that have changed quite a bit, which we're going to cover that also. I'll link it below. But a lot has changed as far as data and evidence and such for these drugs in the last couple of years. So my buddy, scientist, all-around athlete, Erik Bustillo, is going to be come on board shortly. He is a clinical nutritionist, works with at the clinical level with people. So, real world evidence, not just a book geek like myself sometimes, and works with police officers, has done a lot of hands-on, also works, he's big on CrossFit and that type of thing. Can't call myself a CrossFit expert by any stretch. Let me bring Erik in here while I'm blabbing away. There he is.
Hey, Will.
Hey, man. So I just, quick intro on you. Of course, I probably just, tortured the shit out of that. But I did
It was
that.
fine.
I also forgot you're also working away on a PhD, right?
Yep. Yeah. I've been a registered dietitian for. I started losing track of the years. I just say well over a decade,
Right.
with experience in the strength and conditioning world as well. Things like medical nutrition therapy on the dietary side of things,
Mm-hmm.
performance nutrition, weight loss is definitely something that seems to be common in the United States for dietitians, among other folks. And yeah, the tactical athlete space, police, fire, military, army, navy. I mean, FBI, Secret Service. I've had the opportunity to work with so many different folks,
Right.
as well as NFL, MLB, WNBA, tennis, golf, just a variety of people looking over blood work. I've seen people on all sorts of medications, all these different things. And, I try to keep up with the research that continues to come out. And I do want to take a moment to say I appreciate you and your work. I really appreciate your videos. Also, as a side note, if you hear a child in the background, that's my niece. She runs around sometimes and screams.
Okay. Yeah, I was
Um,
gonna say I didn't think you had any kids. So if you
not yet, not
if
yet.
you had a kid and not told me about it, I would have been sort of surprised about that. So okay.
Not yet.
All right.
But yeah, so just a variety of experiences, and I appreciate the work that you do in
Thanks.
summarizing things in your opinion. You are, whether you see it or not, you, like other friends of mine, like Dr. Sue Kleiner and Joey Antonio. I
Mm-hmm.
consider you guys legends in the game. So definitely grateful for you.
So thank you.
Sure thing.
Legend these days. Legend is a very nice code for saying old. But we all appreciate it. Like I say, we're all. I think Sue and Jose and stuff and I, we're all kind of in the same. I think we're in the same ballpark age wise, which is we can say that we were in the space and doing this before there was an internet, which is hard for most people to even believe that there was a day where there was no internet.
Yeah.
And
Yeah.
doing writing in the the print publications and all that's that's where I started out. And I met Jose, I think before he even, I don't think he even finished his PhD when I met him. If he had, it was brand new. He was pretty young. I mean, we're talking like mid 90s, early 90s,
Oh, wow.
something like that. So, and he was working, he was doing some work for trying to think, MRS. I think it was I'm trying to think of who he was working for at the time, because he's done some work between his educational stuff and teaching and research and all that. He's also worked for a number of other companies and such. So yeah, we've been in the game a long time. I mean, the good news, at least I think in this conversation for people watching this also, is that again, you as a clinical nutritionist who's been doing this a long time, have a lot of what people like to call real world experience, which is important because I assume you learned quickly that what you were taught in school and what you did once you got out of school were radically different as far as what you would have to deal with.
Yeah, there's uh, what I learned in school definitely has a place or a
Yeah.
time and place. However, I was always lucky to, when I was doing my undergrad, because of the internet, Facebook, the social media platforms, and the ISSN, I was always kind of like an outside the box thinker.
Hmm.
So I remember telling one of my professors, who I'm still friendly with to this day. She's retired and all of that. And but in one of the classes, she had mentioned something about protein and the kidneys. And I was an undergrad student, and I mentioned something about not not necessarily being the case. So again, kudos back to you and
Hmm.
Joey and Dr. Kalman, also
Yeah.
Doug.
Sure.
I mean, because of you all, that has also helped me in kind of thinking and seeing things differently. But to your point, once you get into the quote unquote real world, you start seeing how business functions. You start seeing what people are actually doing, right?
All
It's
right.
not just you're reading this in a book. Like you're hearing, I worked with a bodybuilder one time who was taking insulin, and that was my first time ever hearing that
Mm.
early in my career. And I was like, wait, you're taking insulin and you don't have diabetes? And then obviously you come to learn that yes, people take thyroid and uh, obviously testosterone and insulin and different forms of medications, diuretics, just
Right.
for physique. So
Well,
yeah,
also, yeah. I mean, I don't think I'm being too cruel by saying that as a rule, nutrition programs, it certainly, maybe they're better today. I think they're probably a little better, but in general, they don't tend to reward out of the box thinking, or out of the
yeah,
box thinkers. Um,
sure,
Now, speaking of protein, it's funny that you would say that because I don't know if I think I ever told you this, but I was actually in a nutrition program for about a minute. But the reason I left was very similar to something you just said. Now we're talking early '80s, so this is a long time ago. But
yeah,
I thought I wanted to be a nutritionist. I was going to Keene State College for my undergrad, which had nutrition, and I had um, I had applied to the program. I don't think I was in the program officially, but I applied to the program. I was on my, I don't know, second or third nutrition course, and one of the I don't know, it was tasks or whatever it was, assignments. I guess that's assignments. Was to write down everything you ate for the week. I remember it very well because this is how I left the program. What you ate for a week. Remember, no, we didn't have, I mean, we would to do this. Remember, we had a calorie counting book. We had a calculator and a pencil. There was no plugging this stuff into, a program and having it pop up a nice sheet. Nothing of that. So,
yeah,
this was like a pain in the ass to do this. But anyway, so we had to, for the assignment for the week was to write down everything you ate and then write up, calories and macros and all that. So I get my paper back and I got a bad grade, and it says that I am eating too much protein and I'm going to damage my kidneys. And I'm so I went to so I got like a C or whatever it was, and I went to the teacher. I said, wait a second, you know, even then I didn't have any real science background, but I at least knew to ask some questions and say,
sure,
hey, what is the evidence that you're giving me this poor grade because I did everything this you asked for? And she said, well, it's just well known that if you eat, the amount of protein you're eating, because I lifted weights at the time. I was, I was really into bodybuilding then. And she said, no, your grade stands because you should have known better. We already told you that, above the RDA. So I went to the head of the department. He backed her up. He said the same thing. And I said, I'm done. I'm out. You people are idiots. And there was no
that's
evidence
crazy.
one way or the other. Now I couldn't remember, again, we're talking like mid '80s. It wasn't, again, I couldn't just walk into the library and go, we didn't have like a big medical, up in New Hampshire. We didn't have a big medical library, something where I could have gone
Mhm.
and, I would have had to go in and like found the microfiche and ordered the journal. And anyway, so that was it. I said, I'm out. You people are way too stupid for me. If that's how you're going to treat somebody, and neither one of them. Now, all I asked for was show me the data. I said, what is
Mhm.
the evidence? There was no evidence. All I got was, so anyway, hence
Yeah,
my lifelong, and my experience has never gotten any better as far as that sort of thing. So there's
yeah,
but I mean, it sounds like you actually had a not dissimilar experience, but it
yeah.
sounds like the outcome was better. Like, at least you didn't, it didn't sound like you got a bad grade or something because of,
No,
your
A-
pushback. Yeah.
At all. It was just kind of like and I wasn't trying to be like, a smart ass or anything
Yeah.
along those lines, but I was just kind of like, that's not what the data show. But you know, I think we have from when that happened with you and when this happened with me,
Yeah.
there were, you know, at least a couple of decades in between.
Mm.
And the reason I say that is because research, right? The
Right.
research it evolves, it grows, and we learn new things that we used to think were bad, and then they're not necessarily so bad, which I think kind of leads to some of the GLP-1 things that we'll be talking about today.
Yeah. Right. So that's good. All right. So at least, I mean, at least that was an improved, well, a lot of things have come up, like say your ability to access data, or at least something that countered the dogma, the common quote unquote known evils
Yep.
of protein above the RDA. You were able to counter it with evidence that again, to some of the people that you were talking about, such as Jose and stuff, are literally responsible for that data.
Yeah.
That of changing the dogma slowly but surely. Which is nice to have sort of been in the ground floor from those people that also questioned. Like I say, that was one of the reasons that Jose and I got along because so well. Because again, he was told flat out by advisors and stuff that he was going to ruin his career by
Yeah.
pursuing the evils of protein. That actually doing studies on protein and stuff. He was warned, that this was a not a good direction to go if he wanted to, have a future in academics and stuff. So imagine, anyway.
Yeah. Yeah.
So,
Yeah.
um,
Times-
so catching up to modern times, obviously, you can't leave the house or be in the house without hearing the talk about of GLP-1 drugs and how popular they are, and I'll get to my own thoughts on it, and to say like that, I've kind of changed them a bit. But what is your sort of mile high view of the use of these drugs and their popularity? And where do you sort of stand on them?
Yeah, it can be kind of tricky to answer briefly, and I
Yeah.
like to try to be brief. But it's just in working with people and seeing how trends kind of come and go. Um, my initial fear or concern with GLP-1s was that they were just going to become the next, for lack of a better example, phentermine. Let's just say,
Mm.
meaning somebody takes this medication, and I worked with these people. I saw it before my eyes. They were not necessarily ready for change. They were ready to take the quick fix. And I don't want that to sound like I think that these medications are only that. There's so much more to these medications. But some people just were not ready. And that trans theoretical stages of change, um, they were like maybe even they were just nowhere ready for any sort of action other than taking a medication, which I think is an important note. So that concern of people just taking or using GLP-1s as the solution was what I was afraid of. People are going to gravitate towards this. This is the answer. I don't really have to worry about making conscientious dietary changes, like putting effort into that, putting effort into lifting weights, which as we get older, we want to support muscle and bone mass, and weights help with that. So that was my concern, is that it was just going to be the next quote unquote quick fix. Same thing, similar to like bariatric surgery and gastric bypass.
Yeah.
No, I don't consider any of that cheating. You won't hear me say that these people cheated to lose their weight. Um, However, if we approach it with this is the solution and we don't consider lifestyle factors, that's where I say, hold on, this is where it's wrong. Um, so as far as the GLP-1s go, they are effective. We know that they work. They work quite well for weight reduction, blood pressure reduction, controlling hunger and appetite and satiety, all the things. Uh, I think that the biggest concern is the what happens next. Will someone be able to come off of these medications and continue to thrive and do well, maintain their overall health, positive health outcomes that they are starting to see, or is it going to be a forever medication? And I think that we're starting to see that that might necessarily be the case. At least in some studies, we've seen that. Because I'll shut up after this, so because obviously I want to hear what you have to say too. But we've turned it into it's capitalism, right? And I'm not trying to turn this into a political conversation, but
Yes.
we're seeing, can we make money on this? Okay, great. Will insurances cover this? Maybe, maybe not. You have the wealthy, thin people that I think you and I would consider thin, but to them, in their eyes, there's major body dysmorphia, and they have to lose the 5 pounds. And it's a 5'6" woman who's already 130 pounds. Like, you don't really need to lose
Who
much more
doesn't
weight.
who doesn't really exercise or so
Exactly.
the interesting background on the GLP meds, which actually leads into exactly what you're saying, is that they've been around obviously for decades as anti-diabetic medications, but
Yes.
they were the sort of secret sauce in Hollywood for a while for actresses and stuff that needed to lose 5-10 pounds or whatever for a role, to lose some quick weight. They were kind of this secret quote unquote drug that trainers and stuff gave them, and which then at some point, some years ago, it sort of was a whispered thing among exactly these people who tend to have let's say body dysmorphic situation, and like say they only need to lose, or they don't really need to lose, but they want to get skinny for a role or whatever.
And they had the money to afford it.
Yeah, and had the money to afford it. Right. So they had the money to afford it, and along with some other goodies, we'll say, we're using those. Like I said, we're using those drugs, and so it wasn't. And then that sort of got out, which then unfortunately, of course, appeals to a particular subset of people, probably mostly women, but not always. As far as like I say, they're looking for the quick fix to lose that quick 20, that 15 or whatever type of thing.
Yeah.
So all right, so I think you and I are on a similar page. As I alluded to in the beginning, that my sort of this was my personal position on them when they were sort of becoming popular and people were prescribing, which was, again, I'm the same page. I don't consider them cheating. I have nothing against if there's a medication that helps you get your goals and is otherwise relatively safe in comparison to those other risks, which again we have to discuss that. A lot of people are sort of incapable of understanding the sort of risk benefit here, but we'll get to that. But anyway, if there was a medication you could take that would allow you to achieve those goals while you were doing the other things that you needed to do, the lifestyle changes, great. I'm all for it. So my sort of attitude was, if you use this med appropriately, like any med, which is it's a part of a lifestyle change, and then you get the goal that you want, and you can then, let's say you wean off of it, and you go on with your life. So to me, I saw it as a temporary benefit. And the reason that I have recently kind of come to at least alter my view, I haven't done a 180. I'm not recommending it, but I really changed who I think it's for, is that some of the data that's come out is at least suggesting, the data is not that strong yet, but anyway, there is data suggesting consistently that even people that made those appropriate lifestyle changes, lost a bunch of weight, still put most of the weight back on. And that is, problematic in my view. I think what that is leading us to, which I think a lot of people are finding out the hard way, is that for many people, they may not be able to come off. This may be a chronic, this may be a lifelong use of this medication. And now again, I think we could go into a whole topic of, depending on how you view obesity, of course. I mean, again, if you're viewing it, let's say, as a chronic condition, I'm not going to say disease. I personally really have, and there's a big battle out there in the medical community as far as they want to list obesity as a disease state. I kind of stop short of that. But regardless, for people that this is a chronic condition, it is very likely that they are going to have to be treated chronically with these drugs indefinitely, which is to say that that's not an unusual reality of a lot of drugs, that people take. Some drugs you take temporarily, like an antibiotic for an infection. Okay, you take it, infection's gone, you're over. But there's a lot of other medications that maybe the best example for people would be like, testosterone replacement. Or hormone replacement for women or something. That's the kind of thing that I think they understand, that sort of once you're on that, you're on it. You're not doing it for a time and coming off. You're not going to come off TRT and somehow your normal system is going to boot back up better than when you started, right?
Yeah.
So I do think at least people that are looking at these GLP-1 drugs, depending on their situation, may need to, like I say, they may need to view this as something that is a long-term commitment. And, at that point, you do have to look at, of course, cost, because these are not inexpensive drugs. I think they've gotten less expensive, but they're still pretty expensive. And then you have to also look at, risk benefit of long-term, side effects kind of thing, which, is probably an important discussion onto itself. I'm sure you.
Yeah.
The other sort of big fear, sort of like fear bubble mongering thing that kind of came up with these drugs, which was an unusual amount of loss of lean body tissue, lean body mass.
Yeah.
With people on these drugs.
Yeah, I think one of the biggest things with that, and now I'm going to put my practitioner hat on. Some of the things that I saw when or see, not full disclosure, I haven't worked with anyone on a GLP-1 in, it's probably been a couple of months or so. Either way, with some people, you see low energy levels. The drastic caloric consumption change is a big one for them to handle. Now, some people tend to feel better when they were eating less. Now, their weight loss is quite rapid, so that helps them feel encouraged or motivated. But a pretty common issue that I would see is that people were just taking the medication. And what I mean by just taking the medication is that they were not resistance training. They were not focusing on getting adequate protein, at least not before they started seeing me. And then even when we started making these changes to focus on getting adequate protein, even trying to bump up calories a little bit, because, I mean, you can survive on 900 calories a day, but that's probably not going to be optimal. And then, other things, right? There are other things for us to consider, like creatine to help support muscle mass. In fact, even something like HMB, that might be that, maybe it's a stack of protein, or at least EAAs and creatine and HMB, and throw that in there if the individual is not going to exercise, because we have to consider we're taking this medication. If we're taking this medication, the very common side effect is decreased appetite, because now hunger regulation is very controlled by the medicine. When the hunger is not very high, calories are not going to be very high. That's where we see that drastic weight loss. Calories are our source of energy. So if we don't have enough calories and energy coming in, how is someone going to do, any form of high intensity training, or even are they going to have the will and energy to want to go and do it? So then it's kind of like when these studies show the loss of lean body mass, to me, it's not surprising. And it's also, it's unfortunate that that's what kind of only gets talked about, because it should be kind of like, hey, yeah, they lost lean body mass, but guess what? There wasn't a resistance training protocol. Right. There wasn't this hyper focus on protein and so on.
I think that particular worry or fear has come somewhat back around to the things you're talking about, which is, yes, if you lose a whole bunch of weight really fast, a large proportion of that is going to be lean body mass. This is well known. It's not anything surprising. So the question is not that they lost a lot of lean body mass. Is it, again, if they are doing something to counter it, resistance training, adequate protein, maybe some supplements, as you said, would we still see it? And I think you're right. That would counter it. But what we need is some data. We need at least, like obviously I would feel more comfortable if we had some comparative data, which is going to be really difficult and expensive to do. The problem with these kind of studies, people always ask, well, how come there's no studies? It's really hard to explain. And I did a whole video on why we don't see more good data, because it's really difficult and expensive to do.
It is, yeah.
And so let's say we had a study. It'd be great to see a study, obviously, where you had you had a group on both following the same low calorie diet, one getting GLP, and tracking to see if they lost equal amounts of lean body mass, right? Which would be a fabulous study. But I mean, who's going to do it, and who's going to pay for it? I mean, and I hate to sound, I have a sort of, obviously love, hate, or pro con opinion of pharma and all that, but they are a business. They are in business to make money, right? I mean, that is what it is. They're not going to be real motivated to do a comparative study like that, really. The NIH isn't going to do it. So I guess I think most of those big fears of what you were saying, or what I was saying and you were saying to counter it, are probably accurate. But the other problem is that, again, going right for the negatives, of course, as when you're an influencer or whatever, that's going to get the interest. When you say, oh my God, everybody that takes GLP-1 is losing all their muscle mass and falling apart, and so the reality of most of this is that it is clinically individual to the person. And what their situation is, and you still got to make those individual assessments of what would be best for them. But I say for myself, I'm fairly comfortable thinking that negative, it would be countered by resistance training, like I say, adequate protein. You've already got, unfortunately, you still already have people with the credentials, the science medical credentials to know better, out there telling people they're going to harm themselves by adding protein, by having extra protein. And I just put up a video yesterday, in fact, on Facebook, from a guy who went on about how extra protein, is going to rot your brain and something. It was a very strange video. You saw, I think you did say something about it. It's right. Very strange video. It's
just it blows my mind. When will this end? Right.
Yeah, it is just, it makes I kind of put those kind of people into two groups. I kind of lump them into two groups. There's the groups that don't know what they don't know. Okay, they don't know any better. Yeah. That are either just that's one group. I'll kind of give them. I will try to sort of give them a little bit of benefit of the doubt in terms of where that's coming from. And then there's the group that have the credentials and the background to know better, that are still spewing. And them I don't give any break to at all. None. They will get just. And I hate to sound too mean about this, but I'm gonna throw your profession in there. In a third group, or let's call it version 0.2, is I break them into, say, medical doctors and whatever, who should know better, but okay, they get very minimal to no training in medical school. They haven't kept up with the data. I'll give them, again, they get a little buffer from me. I'll say, hey, you might want to look into that. I'll send them a paper. Maybe I can bring them out of the, and then the other group, which is nutritionists like yourself, who's literally, this is their bread and butter. Yeah. And so if they don't know that stuff, I have to say I'm not usually very nice about it. They don't get any leeway from me, is what I'm trying to say as nicely as I can, because this is your lane. And you are good about this. You've always been good about that. But I will say that I do sort of break the how hard I'm on people. how sort of much do I try to at least kind of work with them to bring them up to speed and say, hey, maybe you just haven't kept, give them a little bit of benefit of the doubt, medical doctors, whatever. But anyway, sort of do work my way down to and there's a couple of groups that just don't deserve any leeway, any quarter, as they might say.
Yeah.
So anyway, that's my tangent there. People can take it.
I think a big part of that is that we have to take the belief component out of nutrition, right? So something that I saw a lot when I was a student was, people thinking that going vegan is the only way. And nutrition is a science. If you're a registered dietitian by training, you are a scientist. Just because you practice veganism or whatever, keto, whatever it is, it doesn't necessarily mean that it's the best and only way, but people have a hard time separating from that. That's one component, is that the belief component. And then you have years of saying things like protein is bad for kidneys. To defend my profession, we are seeing improvement, thankfully, throughout the years. And, I will say, in large part, this has to do with the International Society of Sports Nutrition.
Mm-hmm.
And people like yourself who put information out there and can be objective about the data. And now we're starting to see that the dietetic governing body, if you will, they're starting to have people from ISSN at their conferences and whatnot. And now, why is this important? It's important because dietitians are going to work directly with people who are taking GLP-1s. We cannot be hesitant nor afraid to recommend getting adequate protein. Dietitians by training are not experts in exercise. I'm a little bit different in that I am a strength coach, and my master's is applied exercise science and sport nutrition and all of that. But we know that supporting exercise is always going to be important. Now, the GLP-1s they're not, in my opinion, they're not slowing down. They're going to stick around.
Yeah.
They're going to be here for probably forever, especially if it turns into like this lifelong medication that you have to take. Like, you made a good example of people on hormone replacement, most likely, if they're going to do it correctly, are going to be on it for the rest of their lives, because once the body stops producing that, now you're relying on this exogenous source of it. With something like GLP-1s, there's a good chance, at least from some of the studies that are out there, and you shared a couple of good papers with me, based on what we're seeing out there. Yes, we know the direct impact is on the hypothalamus, which is going to have an impact on satiety and all of that, that's what leads to the weight changes. People have a hard time controlling their nutrition, right? They have a hard time controlling how much is coming in. And the GLP-1 basically makes it easy for them. So now they have these great results. You take away the GLP-1, then what? Are they still able to control their caloric intake? My judging by my experience in working with people is that maybe it'll last for a short period of time, but generally speaking, most likely not. When you're having this powerful impact on your physiology, then it's not a very good thing in the future.
Maybe GLP is going to, for not everyone, but for a large percentage of people, maybe the GLP-1 drugs are going to be almost have to be viewed as like de facto HRT, because they are. It is technically an HRT. It's just a different hormone. But what are you manipulating? You are technically actually manipulating glucagon-like peptide. Maybe if people mentally are able to view it that way and realize this may be a long-term, lifelong commitment, again, which some people will probably decide not to do it, based on that reality. Maybe some people knowing, that if they come off, have to be better prepared for all of the benefits as far as what people refer to as food noise, comes back. The food noise as I notice is a term that a lot of people, users of GLP use that term a lot. That is, and it's hard. I bet it's hard to explain unless you've tried it. But, or you have problem, but they refer to this constant food noise that just goes away, which comes back, like I say, when they stop. So, and it's, again, I don't really want to beat up on medical profession or even the pharmaceutical industry or whatever, in terms of it's not really, it's unlikely that they are going to do a great job of explaining that to people, because they want you to come in and also, I mean, I know a number of medical doctors that, use these drugs, and they're just really happy that something works. I mean, they're genuinely, they're not doing it for, profit or because they're evil or anything. They are genuinely used to working with people that struggle and get minimal to no benefits on everything else they're doing. And it is exciting as a doctor, as a medical doctor, and as a human being, to see people feeling better. You can't, the doctors that I've talked to, a few actually, that are weight loss specialists. I mean, when you're working in a clinic where most of the people that you're working with, at least at that time, are happy to see you and feeling better, and their labs are all better. You can't, you really can't blame anybody for being a proponent of that,
Yeah, absolutely.
And I do think, again, like everything, human beings being what they are involved, I think there's definitely a spectrum of people, clinics that are popping up that are just straight up, profit driven places, which again, just like the testosterone mills, at least here in Florida, there's always going to be the spectrum for sure of people that obviously don't really give a damn about your health and, are just trying to hook you up. And but the number of doctors that I'd talk to, they just are thrilled and happy to see people that are benefiting, and by the numbers, and certainly by the numbers, they are benefiting. I mean, like I say, all their labs improved dramatically. And as we mentioned early on, these medications have been around for a long time for diabetes, and I also am somewhat curious, and there isn't a lot of great data on this, but I'm also somewhat curious, is that people, again, get, including, again, I'd say medical people that maybe should know better, but anyway, get sort of real excited about, they are attributing a lot of these benefits to the drugs. That is, reduced glucose and A1C and all kinds of wonderful things. But is that the drug, or is that the weight loss? Because this is where we get into the thing you said of the belief in a diet system. Say, I went on keto and all my labs got better, blah, 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 blah. But it wasn't the keto, it was the weight loss. Because if I do if I put you on another diet, a vegan diet, whatever, of the same calories, and you lose 30 pounds, all your labs are going to look fantastic. Weight loss onto itself is very beneficial to all however you get there is, almost a separate topic. You could break it down. Sure, one way of doing it is better than another, no doubt, but I've also put up, this sort of brings us back to the calorie fight, but, there's been now a handful of people that have gone and ate at McDonald's every day for 6 months and lost 30 to 100 pounds. Why? Because they did it, they were in a calorie deficit. So all their labs got better. So you can go and eat in McDonald's every day. Not that I recommend this, but I'm just saying, if the calorie deficit is there, it's the weight loss itself that is the driver of all these wonderful metabolic benefits. So again, I am both curious, and there's no doubt, I'm sure the drug probably does have some individual effects separate from that of the calorie, but I'd like to know what they are. And I am curious again to know what those are. I feel like people individually, maybe say even some medical professionals, give these GLP-1 drugs maybe a little too much credit for all these wonderful changes in labs that we see. Like you say, the the key thing is here, like I say, is the fat loss, and there's no doubt you can optimize your impact and your benefit and all the wonderful things by some resistance training and I basically for myself I basically sort of because all right, people throw up their hands and go, okay, I'm confused. What is the best diet? All right, me personally, the best diet as a core where you can work from would be like Mediterranean style diet as your sort of basis of, where do I start? Because again, sometimes people, there's a lot of signal to noise out there, as you know. So me personally, I'm going to say, okay, we don't have you talk about it. Let's just Mediterranean. For longevity, general health, weight loss, Mediterranean. If you want to maintain muscle or gain some muscle, Mediterranean plus extra protein. Done. Worry about something else, I mean, I'll take it as simple as they want it, or whatever you want to be in this conversation, we can, because again, you and I can throw these things around, and the average person, though, just there's so much, the signal to noise is very high. So I will tend to default them to say, okay, you can go get a book or follow some good websites that give Mediterranean style, recipes, type of thing. Mm-hmm. But I, at least for my own curiosity, I would like to see maybe more sort of parsing out of what is the actual benefit of we can attribute to the weight loss versus the drug. And I think there are, like I said, I have no doubt the drugs onto themselves have some, some separate effects type of thing. But
most definitely.
Yeah.
There's that's an interesting point there because there's I don't know that it's been quote unquote proven yet in the data, but it seems as though we know the weight component, we know that is very real. We know that I don't want to say everyone who goes or uses a GLP-1 medication loses weight, but that is a very common side effect that comes with using the medication. There's something out there where the medication might have this direct impact on something like blood pressure, for example, where the blood pressure it gets better with using the medication, but then once someone comes off of it, even if the weight is still staying on the lower side, like they don't really gain much weight, at least at the start of it, it seems as if the blood pressure does go up. And, the reason I bring this up is because what's going on physiologically, right? So from a physiological standpoint, is there something there with the hypothalamus? Is there something that's affecting the kidneys? And how much salt is getting excreted? Or are we saying, hold on to it, let it go? Because if it's triggering it to let go of, to not retain some sodium, right? Now we're kind of wasting that away. What impact does that have on blood volume? And then blood volume, what impact does that have on overall blood pressure? And so this is just one little thing that we maybe don't know yet for sure, but what else is this, right? So the idea of being on this medication for forever, I don't want to say that it's good nor that it's bad. I think that there's still a lot for us to learn about GLP-1s, but they're a tool in the toolbox.
There is a lot of interesting, both to me, both worrisome, somewhat worrisome, and interesting that there is no doubt a lot of things going on with GLP-1s that are yet to be elucidated and understood, and they are without a doubt, and it is very. And we're getting much better about it. I think both scientifically, research-wise, we're getting better for sure. But it is just sort of the model of Western medicine to look at things in isolated pathways, as not somehow not impacting other things. Yeah. And that's just the nature of how Western, medicine works versus, say, Eastern, which sort of see things as a much more larger picture, and sort of appreciation for the fact that in one respect or another, everything somehow affects something else, whether it's directly or indirectly. But there are a lot of actually very promising things being learned about GLP. For example, sort of, again, quote unquote side effect, but they also are looking into using these drugs for alcoholism.
Oh, yes.
Yeah, one of the quote unquote side effects that people found that when they were on the drugs, they also didn't want to drink. And so they are examining and doing studies, I think, right now with other, like opiate addiction, alcohol. And so there may be, some really promising utility to these drugs via mechanisms I don't think are well understood. I mean, obviously it has something to do with, reward center. Somehow, obviously, this is related to the reward center of your brain, no doubt, where food, of course, has that too. But I, as far as I know, I won't say I've looked into the latest on that. But I don't think anyone knows exactly how that's happening. There are, I guess we're all right. So I don't want to keep people. We've been on for 45 minutes, so an area we can cover and then get off. And then if people have questions, they can leave them below. Obviously, sub up, like this video for us. And if we get some good questions, Erik and I will follow up on future videos and answer these specific questions and other questions. Sure. What I want to segue into a little bit also is a concept. Again, I don't think a lot of people with the credentials should also appreciate, but certainly the average person is understanding the risk benefit, which this is where, in general, across the board, these days, whether it's politics or anything else, nuance and context doesn't exist anymore. It's like
out the window.
Out the window. Right, wrong, black, white, doesn't matter. All right. And that also applies to these types of content. I mean, we are now having these, no in between, no, and if you don't have context and nuance in these conversations, especially we're talking about drugs and diet or whatever, you're never going to have answers. You're never going to have benefit. So to that end, my point, and I am also starting to see again some of the sort of hysteria over, because this is how some people are going to get likes and followings and whatever, is to talk about, quote unquote terrible side effects of these evil GLP-1 drugs without any appreciation or understanding of, context, risk benefit. I think one of the important things that people need to appreciate and don't realize is that what you need to look at with the use of any drug, but we're going to stick to this drug particularly, is that you use the drug and maybe there's a very small risk of stones. I've read that there is a small, but what you have to appreciate that is against the risk of carrying extra weight is a risk onto itself for a lot of negative things, right? I mean, it's not just the risk of the drug versus no risk. It's the risk of the drug versus carrying around an extra 30 or 50 pounds, which puts you at risk for heart disease and cancer and a whole lot of and diabetes. So the risk to benefit has to be one compared to the other versus just, I see a lot of people saying, I read this terrible thing that I'm trying to think of what some of the more, sort of out there
GLP-1s.
Yeah, sort of side effects that we're reading about. As
far as the GI ones tend to be pretty scary for people.
Right. Yeah. Those are the gastro. Yeah, I mean the the GI ones, at least those are fairly common, but I mean they also tend to go away. I mean, as far as the nausea, I'm thinking something to be like one I've seen out there, blindness. Supposedly, again, blindness. There's no data as far as I know that even associates them with it. And obviously that's very scary. But again, usually as far as blindness that is not attributable to a disease or something, whatever, and we know that elevated glucose, very high elevated glucose, obviously, puts you at risk for blindness because of the glycosylated glucose in the eyeball literally, ruins the lens and stuff.
For retinopathy, yeah.
Yeah, that kind of thing. I mean, that's one. So, but again, if people, you get a lot of attention by pretending, pretending these are common side effects when you need to go look up a little bit, what is, and of course the muscle loss, which again I think you and I are both agreed that may be, again, that too may be wildly overstated in terms of it certainly will have, if you lose 30% of your body weight in 6 months or 4 months, you're definitely going to lose a lot of muscle if you don't, but I like pancreatitis. There's one that just get one of them that's pretty rare, gallbladder, pancreatitis. Those are side effects that I think do exist, like in the data, but they're really rare, and they usually tend to come with the higher doses, and they also tend to come with probably, again, as at least partially, if not all, from super rapid weight loss. I mean, again, your liver, your kidneys, whatever, are all going to are processing an awful lot of stuff when you drop. You have 20, 30 pounds, but the point being that if you're thinking of these meds, I don't want to, you're worried about using them. What you really need to do, again, is look at not just the risks of the drug, but what is the risks of continuously carrying around an extra 30, 40 pounds,
Sure.
Now,
yeah.
And one thing I've for decades, I've tried to get across, in whether it's articles or videos or whatever, is trying to get through to people understanding risk benefit, which, again, there's a lot of people who should know better, who have either slept through stats or didn't pay attention or whatever, but these are people with degrees that should know these topics. And I'm going to use an example of another one just because it's sort of hot in everybody, like statins. I've seen medical doctors who really ought to know better saying, I wouldn't recommend, a statin to my patient, because the high risk of diabetes. Mm-hmm. Now, the risk of diabetes in statin users is really low. It's really low. It's like 3%, 1% to 3%. Mm-hmm. 2, it's at the highest doses, which most doctors know you don't need high doses of statins anymore. Sure. And 3, you have to counter it against, again, the lifelong exposure to, let's say, having, really high LDL. So, and this is a person who should know better. So if they're doing it for 2 reasons. They don't know better, which boo on them, because they are high level MDs or PhDs, or even worse, in my view, they're doing it intentionally. And that puts them in the scumbag. That puts them, now you only got 2 choices. You're ignorant, or you're illiterate of the data, or you don't care and you're doing it on purpose. Neither one of those, you've put me, you've dropped, my opinion, you have dropped very low. So back to the GLP-1, people need to not just worry about the side effects, but this also brings us back to the person that you were talking about before we jump off in our beginning of our talk. Let's say you don't have 30 pounds to lose, or you're not at a high risk, you have 5 pounds to lose. Then your risk of that, you have a different risk to benefit assessment to make, right? Oh, yeah. You're making now you're at a different location. So so you only have a 2% or 1% risk of, let's say, gallbladder problems, but you could that 5 pounds you could lose without the drug. You don't really need to take, as low as that risk is, you don't need to take it, because you really aren't in a position where, when you're, but when your physician or whatever says, you've got a BMI of, 35 or, 40 or something, you are at a very high risk of, heart disease and so on and so on. You may benefit from these drugs, type of thing. And then you go look at Dr. Google or some YouTube video of some influencer saying, gallbladder problems. This is where I try to stress this important point of risk benefit, because it's on paper a simple topic, but it can bounce around a bit. The risk benefit equation is not the same for everybody.
Sure.
It changes depending on this. Like, say, are we talking about the person you mentioned, the thin woman who just wants to lose 5 and wants the magic pill? She probably has no business. She doesn't need to take even the minimal risk of, let's say gallstones or gallbladder or, pancreatitis or something, all of which are, like you say, are very low. The GI stuff is not serious, but it is fairly common.
Yeah.
And the way, in my experience, you can avoid that in most cases, not all, but most, which a lot of doctors, again, don't do, is to titrate, start with a much lower dose than you were prescribed and titrate over time. And you may even find you don't even need the full dose. I know people have gotten pretty good results off much lower doses. But unfortunately, in my experience, most doctors prescribing it, again, aren't great at it in terms of, titrating both up and down. Again, you go from using this drug, and as you were saying, you stop it. Well, there may be a fairly metabolic, severe, rebound response there, type of thing. And it may be a little complicated, but definitely, in my experience, as far as most of the common issues like GI stuff, whatever, taking some time to titrate that dose from something low and increasing it every couple of weeks for 6 weeks up and back down seems to be beneficial in that department. Or as you titrate up, you may find the magic dose that causes you those problems and can just sort of hang back right there and say, okay, every time I go to this dose, I throw up or I feel awful or whatever. I've known it's a smaller group of people, but it's not tiny, who couldn't use GLP-1 inhibitors because they said, well, of course I didn't eat, I was throwing up, and well, that's not good. I mean, that's not what we're trying to achieve here. There are some people that have a pretty severe response to it, but most of them, it's just sort of nausea and they don't feel well and it goes away. But anyway, that would be my only tip.
Yeah.
For those that are considering.
I think that the individuality component is extremely important. People can respond differently. In large part, people might respond in a very similar fashion. But the risk-reward conversation, I wholeheartedly agree. We have to have that conversation. What is it that is stopping the person who wants to achieve that 5-pound loss? What's stopping them from quote unquote, just making these dietary changes or optimizing their training? I can tell you with the people that I've worked with, they were definitely not doing what was optimal. But also, I remember one person in particular, they could not achieve the weight loss, and they claimed, and I say claimed because I was not there with them 24/7, 365. They tried everything. They tried increasing the protein, just general things for overall weight loss, and they could not do it. And their statement was, the only thing that actually worked for me was the GLP-1 medication. Now, is there something there? I'm not sure. Obviously, in working with people, we know that human error is huge, right? We think we do way more than what we actually do.
Yeah.
And there's always that. However, at the same time, and I definitely don't want to dismiss anybody's particular goals or anything like that, we have to have the conversation of weight and body composition. It's an important part of the conversation.
Yeah.
I'm all for body positivity, but not in the way that I think people promote it. I think that people should be happy in their own skin. Like, why not? If you can't be happy with yourself, then dang, it's going to be a rough life. And it's not a but or an or, it's an and. And at the same time, we have to acknowledge, if you are carrying excess weight, or if you're someone who's underweight, which could be dangerous too, but that's not the common problem.
Yeah.
We have to have the conversation because we know. And Will, you and I both know our population in the U.S. is not over muscled. So the BMI is going to more than likely be excess body fat.
Yeah.
But
yeah. And I would say, just quick, when the BMI first came out a long time ago, I have to admit, I and many others were just totally against it. Just
Yeah.
because it totally penalizes, obviously, athletic, bodybuilders, athletic population. And as time went on, it maybe I just, got more mellow or reality. The reality was, just as you said, the fact was I had to readmit that applies to so few people, that are of that athletic population, that the BMI, I think again, like a lot of others, the BMI is misused a lot. Unfortunately, it's great,
Sure.
population-based, numbers, or population-based, looking at people, it works fine. And as you said, most people that's excess fat, it's not excess muscle. I think the mistake is that, again, some doctors and whatever use it on individuals. And, I even now, my BMI is, and I'm not, I'm a lot smaller than I used to be, but there was a time my BMI was like 30 and I had 7% body fat. I was not, and the doctor would look me right in the face and say, you could stand to lose some weight. And I was just like, oh God, So anyway, that has changed, I think, along, like Joey and Jose and stuff. He and I used to, he was not a big fan of the BMI back in the, but I think a lot of us, as time has gone on, are more come around to your position on it. Like I say, that is, yes, it does, of course, it's not beneficial to, athletic, muscular people, but that is not the U.S. population. And I think the vast majority of people, we know what the BMI means. I will say again that I think it is definitely misused when you try to, any population-based thing, you cannot narrow down to an individual and apply it to the individual as the be-all end-all. Your BMI is X. Okay, well let's do the tape test. We can do that. That's the tape test has actually turned out to be fairly accurate. So even that, it's not perfect, but of course, at least if your ratio of your midsection to your chest, you can do that. That gives you a fairly good idea. And of course, you can say, okay, well, you work out and let's check your actual body comp. And that, of course, could be a whole other show. We didn't even talk about body comp. I mean, that's
for sure.
I think we could, and maybe we should note that as a future show. Certainly, a point I've been trying to make forever, and we could talk to that again. I'm in definitely the same thing that I'm all on the body positivity concept, and absolutely don't think the last thing we want to do, especially to women, because let's say the women are obviously much more targeted for a body dysmorphic sort of stuff. That I certainly am the last person who wants to try to make women or anybody fit into a specific mold, as far as shape or size or anything like that, which is, so that goes back to body composition and your labs. I mean, when I say to people, again, a whole other conversation, but I mean, again, if you say, well, I like the way I look, and this is the way I'm happy, and my response to that would be, well, look, if all your labs say that you're metabolically healthy, then carry on. Yeah. I'm good with it.
And you know what? I'll add something to that.
Yeah.
Just as a quick side note, how much do they care? That's another thing. Yeah. If you're happy, if you're carrying, let's say you're carrying excess body fat, and you're truly happy with how you look, how your life is, how you feel, like all these things that are definitely important. And if your blood work comes up not very good, but you don't care, I'll have the conversation with you. And I'll say, look, these are the certain risks. But if you don't care to make a change, listen, I'm not in the business of
me either.
Horse to water.
I have a very, very specific rule on that type of thing, which is I will bend over backwards to help people that want help.
Absolutely.
Or whatever. But if they don't, that's fine too. But I won't chase you around. I can tell you that. Now, to conclude, I think all that is true, and we agree on this. The only thing I will say though is don't complain at me when you have diabetes and you're 30. I mean, accept that too. If you say, hey, I don't care, I'm good, and you end up with blocked arteries at 40, hey, then because a lot of people do a full 180 at that point. Go, they completely spin around and look, hey, I mean, it is what it is. But it is if you're somebody who can carry a lot of excess body fat and you are perfectly happy with it and all your labs are fine, you're a unicorn. That is a very rare human being. It's not that it's impossible. You may have such great genetics that for whatever, but you don't count on it anyway. So that's all. That'll be another show for another day. But yes, I think we'll leave off on a whole other good spot that we can discuss, because again, I am in agreement on all of those things, and we didn't even talk about body composition, which is again, where BMI kind of falls apart, but not for most people, and where people really should be focused on, of course, is improving their body composition. But again, that
for sure,
that doesn't sell diets and genes and things like that. That's the problem with that. So we're fighting. That's an uphill battle fight right there. Right? You're really fighting against the market, the marketplace and all that. All right.
Yeah, most definitely.
All right. So thanks for coming on. Thanks for having me. Let's see what we get for questions, and maybe we can answer those in a following show, and we will cover next time. Maybe we'll cover something more nutritionally oriented. We could do evil seed oils. We could do. There's a lot of big topics out there that
there's a lot.
Certainly could be covered, and probably won't change too many people's minds, but one at a time. That's all. If you get one person,
it's enough. One person is good enough.
Right. That's right. All right, my friend. I'll see you soon, and ciao, everybody.